How will the approval of once-daily Complera and Stribild for use in treatment-naive patients affect clinicians' first-line treatment recommendations for this population?
We now have 3 different single-tablet regimens, all containing tenofovir and emtricitabine, and then one with efavirenz, one with rilpivirine, and that's Complera, and then one with elvitegravir and cobicistat, which is Stribild. So the options for single-tablet regimens have expanded considerably. And there were a number of patients who weren't great candidates for efavirenz or atripla, either because they tried it and didn't tolerate it due to CNS side effects, or they were just people with say, mental illness or substance abuse who were also not felt to be good candidates. And for those people, the availability of these 2 new co-formulations opens up options for single-tablet regimens that they didn't have before. One of the downsides so far has been that all of the single-tablet regimens include tenofovir, which means that none of them are appropriate for people with kidney disease. But that will change with the upcoming approval of a abacavir, lamivudine, dolutegravir co-formulation. So that'll be our 4th, and will be an option for people who aren't good candidates for tenofovir. That's really going to mean that a larger percentage of people starting their first-line regimen will be on a single-tablet regimen. Now, there are still reasons why somebody might be put on multiple tablets today. And probably the most common one in our practice is concern about adherence or concern about people being retained in care, where protease inhibitors still have an advantage in the sense that people who start and stop, or who take them with poor adherence or interrupt frequently, are very unlikely to develop resistance on a protease inhibitor-based regimen. So that is still going to be a reason why we might not use single-tablet regimens in everyone. The good news is there may, in the next few years, actually be a single-tablet regimen with protease inhibitors, specifically darunavir boosted with cobicistat, plus emtricitabine, plus the new tenofovir prodrug. But that's a ways away. So I think these new single-tablet regimens have really expanded our options for simplifying therapy for patients, but I wouldn't say that we can put everybody on one of them. And then lastly, I would just point out that with the impending approval of a generic efavirenz, we may be in the situation where we have a lot of single-tablet regimens that we would like to use but can't because of the much lower cost of say, brand name tenofovir with generic lamivudine and generic efavirenz, and then that will sort of be the default regimen that we have to use from the point of view of third-party payers, and can only use these other regimens if we get a prior authorization. So a lot of changes are coming that may affect our ability to use some of these new agents.